fairly straightforward group of disorders. Any particular, well, I mean, if you want to stay focused initially on the musical score, any lyrics linked to any thoughts about psychiatry?
I'm terrible with lyrics, but I know.
And, you know, I have to apologize too, for those of you who have seen this for the first time, assigned by a clerkship director, therefore over a streaming service, that, apologies. The first time you watched this movie should have been at midnight at a theater, surrounded by people, actors, and you should have got home no earlier than 3 a.m. That's the true experience.
Let's see, well, main character Frankenfurter, isn't the song he comes out to, like his opening entrance, Sweet Transvestite?
Yeah.
And that's what he called himself.
So if Dr. Frankenfurter, instead of exiting that elevator, in song, meeting Brad and Janet, instead met you with a white coat on in a clinical setting. His initial presentation is chief complaint. I'm a sweet transvestite. Take me through your thought process about what you want to know. I mean, this individual just came through your clinic door, sitting in front of you, fishnets. Why are you here? I am a sweet transvestite. What do you want to know? You're going to have to formulate questions that's going to comprise a psychiatric evaluation, the reason why he attends your clinic.
Well, I would certainly want to start with that. Like, what is his goals for coming here? What does he hope to discuss? I mean, I do feel like it's a little outdated to call himself that, you know, or if other people are calling him that.
It definitely seemed like he was trying to shock everybody.
Yeah.
Like, I got a little bit of like personality disorder in terms of like his attempts at like causing drama and like turning on others very quickly and like.
Very dramatic, very impulsive.
Yeah. So I guess I would want to find out like, what is this presence about? Like, you know, what are you trying to elicit from other people? Like,
Right.
how long have you doing that for? Like, is this lifetime?
The motivation for the shop.
Yeah. Yeah.
The true value
Mm-hmm.
behind the shop. Okay.
And what are his relationships with other people? Like, does he have a community of individuals that support him, or does he?
Right, because his community seem very much like almost like minions.
I was just going to say, that's the question to ask. That is
Right.
definitely an initial question to ask. And now, having seen the movie, you know the answer. So let's say that he's a reliable informant. He's a reliable patient. And what his answer to that very question is the plot of the film. So now you have that knowledge because you've seen the film.
Right.
What does that gain you?
It seems he likes to be in this position of power, where he has like a certain amount of dominion over the other members of his castle, and he abuses them constantly, either physically or verbally.
All true. You know, I think when we look at the information provided us, and if you look at where we are in this very conversation, the first question that a psychiatrist should ask themselves, is the behavior abnormal? Is the behavior outside a culturally sanctioned norm? Because initially, the thought might be, yeah, it is. I mean, excuse me, that is, it's normal. Right? And I want you to have that mindset when you meet a patient for the first time, irrespective of what the chief complaint is. Even if they're in the custody of the police after being found wandering due to acute psychosis, I want you to train your brain to think that this is normal. Now, what information am I gained that will shift me from my initial view? And that shift, that pivot, may occur literally within seconds, right? And at that point, I don't want you to think, oh, Toby, I knew I shouldn't have thought that. No, I want you to always go into every situation giving your patient unconditional positive regard and think that this is normal. It is culturally sanctioned. Because even Brad tells us, and you see him model that behavior with Janet stripping down. And while he's saying, It's just probably some hunting lodge for rich weirdos, right? It's normal. Just go with it, right? So I want your brain to be there too. Now, your brain is doing this behind a desk in a psychiatry office. You're not physically there. Of course, if you're physically there and you've entered that castle, please, hypothalamus, fight or flight, get out of there. But I don't want you running like that out of your office when you see a patient present to you with a chief complaint similar to Dr. Frankenfurter's. So this is normal until it's not. Now, I think it's safe to assume, and again, you could tell me, this is certainly subjective, that at some point in this film, you're gonna change your mind, right? You're gonna have the incorporation of new knowledge, AKA the patient's history, that'll allow you to say this is no longer normal. And now we're dealing with abnormal behavior. The next question is the abnormal behavior clinically significant? Is it disordered? Those two terms are interchangeable. Right? Because if it's disordered, the individual must demonstrate to you, through their history, that it is causing clinically significant distress or impairment in self or others. And you already told me that that's true. By the use, you use the word minions, clearly abusive. So the answer is yes. So now we're dealing with a disordered behavior. Right. Any questions about the way to kind of have your thoughts unfold when you're meeting a patient for the first time? And this goes for any psychiatrically ill patient, whether the chief complaint is, I feel depressed, I feel anxious, or I'm a sweet transvestite. So now we're dealing with an abnormality of behavior. So next question. Is this abnormal behavior that you've now observed and identified likely A, part of a mood anxiety cluster, or B, psychotic dissociative? You only could choose A or B. What do you got? There's no wrong answer. Cross. B. B.
Okay, B.
B.
A.
A.
B.
B. 4-1. The B's have it. So we're going to say B. If the consensus is that we're observing a psychotic dissociative cluster, we have to now arbitrarily choose a single illness from which to work. And the single illness that we've already decided on last week that we'll choose when we're going down this path of reasoning is schizophrenia. And that this is not patient-centric, this is not film-centric. We will always choose schizophrenia when we choose B. Right? That's arbitrarily been agreed upon. Does Dr. Frankenfurter rule in for schizophrenia? That is, does he meet 2 of the 5 necessary criteria that define the condition? Well, you can answer that question without telling me what those 5 criteria are. Anyone?
Depression or flat affect. Auditory or visual hallucinations.
Delusions. Disorganized behavior and disorganized speech.
Perfect. You need 2 of those 5 over at least a 6-month period. Now, we don't know much about the events that occurred prior to Brad and Janet entering that castle. However, it appears reasonable to assume that this is chronic. Chronic is operationally defined by the APA as 6 months or more. So that part of it, I think, we should feel comfortable with. Does he have 2 of those 5 necessary symptoms?
I don't think so.
Does he have 1?
It's hard to say, like, if everything that's happening in the movie is actually happening. I don't know. I mean,
The one concern I would have, delusional, is, I think, almost everyone's interpretation of this character, even outside of psychiatry. And that is his whole understanding of the world and even of himself seems to be from vaudeville shows that he's familiar with. He really doesn't know who he is. And that aspect might actually be at the level of a delusion. If he can't piece together a dramatic act and pull from something that he saw from fiction, I'm not so sure he would know who he is, or where he is, or what his goal would be. So I'm a little concerned about delusions here. And again, that's a non-psychiatric interpretation of who this character is. He's just one vaudeville act after another, and he communicates that way. So disorganized communication might actually be in play here, as may delusions. This is the way we're going to play this formulation game. If there's suspicion, we're going to say yes, he meets criteria. And the reason why I want to do this is twofold. Number one is that it gets us to the next step of this teaching process, which of course is important. The other part of it, of course, is that on the shelf exam, this is the way the board questions are usually written. You may not get a perfect 2 out of 5. You may just get 1. And if choice A is schizophrenia, and choice B is conversion disorder, and choice C is anxiety, and choice D, etc., you're not going to leave the question blank. You're going to be asked for the single best answer. And even though you may not reach 2 of the 5 necessary symptoms, schizophrenia is still the best among the group, among the answer choices. So I'm going to kind of ask that your thoughts be consistent with the way you sit for the boards. So we're going to say yes. Right, we're going to say yes, and if we were put in a corner, we're going to say delusions, disorganized behavior. This condition, schizophrenia, is a diagnosis of exclusion. That's our next step here. That is, the investigator must always look into other illnesses that could explain the behavior that, if ruled in, would take precedence. What are those 5 conditions? I think you were going down that road before.
Like depression.
Depression, right? Primary mood disorder. Primary mood disorder.
Oh, just primary. Personality disorder? Substance use?
A substance-induced psychotic disorder.
Oh, psychosis secondary to medical condition.
That's 3.
Like delirium or something?
That's due to a medical condition or the effects of a substance. That would kind of override or kind of sit above both of them as a descriptive, albeit diagnostic term. Schizoaffective disorder. And then finally, autism spectrum disorder. So there is evidence of an autism spectrum disorder, pre-existing condition, in the Rocky Horror Picture Show. A, yes, B, no, C, doesn't matter.
In any character?
In Frankenfurter.
Oh,
So let me rephrase the question. Why is it C? Doesn't matter. The reason why is because the APA acknowledges that there are overlapping symptoms of ASD and schizophrenia. So if an individual with a pre-existing condition, ASD, is demonstrating disorganized behavior, headbanging, and disorganized speech communication, ASD, autism, that is, when they present to another physician, perhaps even at a later age, those same signs and symptoms should not be misinterpreted as schizophrenia now. It's still autism, or autism spectrum, right? However, in someone with a previous condition of autism spectrum disorder, who has new onset delusions, you can still diagnose schizophrenia. So the pre-existing condition here doesn't matter, because you've already recognized that delusions are part of your case formulation. So even if there was a prequel to this show, this movie, and in that prequel you saw a little Frankenfurter demonstrating ASD, you can still case formulate schizophrenia. Any evidence that there is an organic pathology here? Again, organic here would mean either due to the direct and physiologic effects of a substance or an underlying medical condition. And you should take this in 2 steps. Number one, if you geeked out and actually read the script, including the lyrics, anything written that explicitly says that he has a medical illness or is using. I'm gonna take the radio silence as a no, right? No, there isn't. Now, our work's not done yet because paralleling the patient interview, if you ask a patient, do you have any medical problems? Or any medical conditions for which you're currently or previously in the care of a doc, a primary care physician? They say no. Are you currently using any substances? They say no. You can definitively rule out an organic pathology for this psychosis. So, no discrete evidence in the script, no discrete evidence in the plot of this movie. However, we should still keep both substance-induced psychotic disorder as well as a psychosis due to an underlying medical condition in our differential. So maybe a little lower in our differential, but in our differential nonetheless. Is there a mood component to Dr. Frankenfooter? Because if your answer is no, both a primary mood disorder as well as schizoaffective are off the table. If your answer is yes, we have to keep them in our differential as well. We have at least one person that believes the answer is yes. Anybody else agree with her? So we have one, we have two yes, and then a bunch of non-committals. So 2-0.
I agree.
3-0. We're going to actually keep both schizoaffective and a primary mood disorder with psychotic features. Let's say that we go down this road and we discover that those are viable options in our differential diagnosis. Somebody tell me the difference. What differentiates one condition from the other?
So mood disorder with psychotic features versus schizoaffective.
Exactly.
So schizoaffective, you have at least 2 weeks of psychosis alone without mood symptoms. And then the mood disorder is you can have an overlap of psychosis with adjacent depression. Or
So let's bring this back to Frankenfooter to really demonstrate these two other conditions. So again, we're discussing schizophrenia as a possible, most likely diagnosis in Dr. Frankenfooter. And in discussing schizophrenia as an option, we now are looking at two other conditions, one called primary mood disorder with psychotic features, the other called schizoaffective disorder. That if either ruled in, would displace schizophrenia as the most likely diagnosis because the American Psychiatric Association states that either of those would take precedent over schizophrenia. In each case, an individual, Frankenfooter, will present with co-occurring mood and psychotic symptoms, which we've already established because 3 people in this room just told me that they believe there are psychotic symptoms, delusions, and disorganized behavior, as well as co-occurring mood symptoms. So he's a nice case study to differentiate primary mood disorder with psychotic features from schizoaffective disorder. Right, so in either case, you have an individual demonstrating co-occurring or comorbid psychotic and mood symptoms. In a slice of time, including a film, you can't distinguish between one and the other. You can't. No psychiatrist can. However, a patient history that, of course, hopefully will be built into a clinical vignette will get you your single best answer, whether it's one or the other. The patient's history in scenario A is when the individual demonstrates psychotic symptoms without any evidence of co-occurring mood symptoms. When that happens, that condition must be a primary psychotic disorder. Pretty straightforward. If the individual tells you that 2 years ago that they were hearing voices, but had no evidence of depression or mania, assuming that their history and reporting are reliable, the evidence of established psychotic features and the absence of mood symptoms will result in the conclusion that this must be a primary psychotic process. And the diagnostic label for that psychotic process is called schizoaffective disorder. The exact opposite is true for the primary mood disorder with psychotic features. That patient will tell you that at some point in their history, the patient was experiencing mood symptoms, absent any psychotic symptoms. That will tell you as a clinician that the primary problem is mood disorder. And the diagnostic interpretation will be a primary mood disorder, either major depressive disorder or bipolar disorder with psychotic features. So that's the bottom line here. Now, the only other thing that comes up at exams with regard to either of these, both of these, is, well, how long do they have to demonstrate one without the other? Right? So for instance, if somebody presented to me with co-occurring mood and psychotic features, and I asked, has there ever been a time in your life where you experienced one set of these symptoms, but not the other? Yeah, doc, this morning at breakfast. I was really sad, really down, but I didn't hear any voices. That can't be good enough for you. Arbitrarily, based on the medical evidence, in terms of validity and reliability, the American Psychiatric Association says that range should be at least 2 weeks. Not 2 hours, not 2 minutes, but 2 weeks. That's the only other part of this, which may or may not come up in exams. What is much more likely to be manifest in exams is the demonstration of one set of symptoms absent the other, establishing what the primary disorder is and therefore establishing what the most likely diagnosis is. Questions? Do we get any of this information from the case study known as the Rocky Horror Picture Show? I don't believe so either. Right? I've watched this movie well over 100 times. Still haven't figured out whether or not it's schizoaffective versus primary mood disorder with psychotic features. Who knows? One final step in our process. By the way, just to give you a heads up, if we decided to take choice A and say that this was a primary mood anxiety cluster, like you had actually thought, we'd be right back in the very same place we are right now. So making a commitment, choice A, choice B, mood anxiety versus psychotic dissociative, chooses only the path you're going to take, not whether or not you're going to be right or wrong. You're going to be right either way. So we're at the point now where we're about to end our discussion about the most likely diagnosis of Dr. Frankenfurter. And that is a little bit of a thought experiment. If you geeked out and took notes during this film, and right now I ask you to take out that paper and cross off everything that can be explained by what we just discussed, the last 20 minutes of our discussion. Primary mood disorder, schizoaffective disorder, substance-induced, etc. All of that now lands to your crossing out everything on your notes page. Now look down on your notes page. Is there anything left? Because if your answer is no, we're done. If your answer is, yeah, I still got some pathology left on my notes page, that must mean that we haven't yet discovered what the disorder is. So, consensus, nobody here is taking me out, nobody geeked out, huh? Consensus, would you have anything on your notes page left?
What about like a personality disorder?
Well, what about it?
So
What evidence in the movie suggests that there's behavior that has not already been explained?
Sure.
You mean behavior just of the main character
Yeah.
or of outcome? I feel like it's all mixed.
Yeah.
It's a lot.
I feel like personally, I think it's been explained.
It's been explained. Anybody else? Anybody else see anything that you don't feel would be explained by anything we've previously discussed?
The only thing I can think of is like histrionic behavior where he tries to seduce both Brad and Janet.
He rapes Brad and Janet.
Yeah.
As a psychiatrist, are you willing to ignore that and leave that to maybe law enforcement, or is it something you might want to address in your treatment plan?
Definitely address.
Do you, in addressing it in your treatment plan, do you feel comfortable saying that his behavior, this aggressive behavior, is due to one of the conditions we previously discussed?
Or like antisocial.
So the answer is no. So getting back to our original question, there is something left on your notes page, after all. So there's more discussion to be had. All right. Anything other than rape And by the way, rape in and of itself is not a mental disorder. Right? However, it certainly could be linked to one, which is now what we have to figure out, what may be going on with this main character. We're discussing things today, 1 week after the death of Meatloaf. What is Meatloaf's fate in the Rocky Horror Picture Show?
Right, he gets murdered.
And so murder, is murder explained by anything we've previously discussed? No, so there's probably some other stuff on your notes page. Again, murder itself is not a mental disorder, but psychiatry probably would want to look into this a little bit more to see if it's linked to or rooted in.
His idea of like a perfect man.
Yeah. Yeah, I mean, you think he might be an ethical physician in his practice? Right? So not only does he create his quote-unquote perfect man, but immediately after the man's birth, what happens?
He gets him working out.
He chases him.
Chases him in, right, some whips and chains. And isn't there a bridal suite too? What happens to the bridal suite?
Well, he has him cuffed in the bed.
Yeah.
Yeah.
Yeah. And what do? They watch live PD together? What are they doing? Oh, you guys are really buttoned up today.
He rapes him.
Yeah, to consummate their marriage. I don't know if he actually consented. May not have. How old is Rocky Horror?
A day old.
What is this an allusion to? Yeah. Yeah, he's a pedophile. Yeah. Pedophilia is a crime, but unlike rape and murder, it is also a mental disorder. So there's a lot of information here that we haven't yet discussed. Okay? I asked you before, what's Meatloaf's fate? Yeah, he's murdered. What else? It's not just murdered.
Murdered with an axe.
Murdered with an axe, and then he's buried.
Into the table.
He's what?
Into the table.
Into the table. Why is he buried into a table?
Is he obsessed with like dead people too?
A little more than that. He's given a proper funeral, and right? What happens to him? It's cannibalized. Right? I mean, if hopefully when you go into psychiatry, if somebody presents with cannibalism, as a psychiatrist, you're not going to ignore that behavior. So something that probably should enter into your treatment plan. Again, cannibalism to date is not published within the eating and feeding disorders chapter. It is not yet. However, I don't think there's a single psychiatrist that I've ever met that would deem that to be normal behavior. Right? So it might actually be published in that chapter in a later date. Something to consider here. All right, so if you look at the behaviors, some of which we put some labels to, is there a particular chapter in the DSM that we should now kind of focus our attention on outside of the psychotic or dissociative disorders chapters?
That's like whatever area, like conduct disorder and antisocial.
Right, the impulse control disorders, including conduct disorder. The answer, that's true. The answer is yes there. However, we're going to table that one because both conduct disorder as well as other disorders of impulse control, oppositional defiant disorder, are largely relegated to children and adolescents, which is beyond the scope of this discussion. I'm not a.
Does that include your antisocial personality
No.
disorder? Oh, okay. Well,
No.
whatever area that's in.
So antisocial personality disorder has got to be part of our discussion. Any other personality disorders chapter? Any other chapter? Pedophilia, sadism, masochism.
Are they deemed like fetishes?
Yeah, right, sexual disorders. The sexual disorders chapter of the DSM-4 was broken down into 3 parts. As of 2013, in the publication of the DSM-5, they built 3 separate chapters. Number 1, sexual dysfunctions. May or may not be demonstrated in the Rocky Horror Picture Show. We're not going to talk about them today. What I will do is encourage you that in preparing for your shelf exam, bring up an image of the sexual response cycle. Don't do it now. And study it. Get your favorite word review text, review the sexual dysfunctions, and you'll see that on average, 1 to 2 correspond to each stage of the sexual response cycle. Much easier to remember. Much easier to remember. The second condition, which is now a second chapter, and it's the only condition published in the chapter, is gender dysphoria, which Dr. Frankenfooter actually rules in for. Previously known as gender identity disorder, Dr. Frankenfooter actually sees himself experiences himself, identifies as a female. So gender dysphoria, I think, has to remain our differential diagnosis. However, the focus of our discussion today is primarily going to be that third chapter, which are the paraphilias, otherwise referred to as the sexual deviancies, because he is a sexual deviant. So, in reviewing the sexual deviancies, that third chapter titled the paraphilias, the first step is to list them. Okay? So, question: how did everybody here learn the planets of our solar system?
In elementary
Yeah,
school,
elementary school.
and with what is it called, the riddle, not a riddle, like a mnemonic, there we
Yeah.
go.
Do you remember what the mnemonic was? And I'm not going to get into the controversy about Pluto. For now, we'll keep Pluto in or out, doesn't really matter. But what do you got?
Like my mother, oh,
You skipped 1 to 4 there.
oh, never mind. Then this mnemonic maybe doesn't work.
I can't think of what it is.
No?
I don't know.
Between us, or like my very excellent mother
Oh.
makes.
Just?
My very educated mother just served us noodles.
Right?
Oh, or my very educated mother just served us 9 pizzas for Pluto.
That's exactly right. And that's the one I see most common. That's the one medical students report back to me most commonly. All right. So the question then begs, what about your very educated father? Mom's getting all the highlights here, thanks to Mars. Right. My very educated father serves porn for thrills. There's your acronym to remember the paraphilias. Take me through them in order. My very educated father serves porn for thrills. You can't forget that.
Masochism.
Masochism. V. Very. Well, let's go one by one. Masochism. And a quick disclaimer. In the DSM-5, 2013 publication, masochism, which is a deviant behavior, was more identified as masochistic disorder. The DSM, in this case, making sure we understand that just because a behavior, and you're going to define what that behavior is in just a second, just because a behavior might be outside of a culturally sanctioned norm, does not necessarily make it disorder. Right? So if somebody, a masochist, becomes sexually gratified upon being humiliated or having pain inflicted upon them, it might be deemed abnormal. However, if they're perfectly fine within their marriage, there's nothing further for a psychiatrist to render. However, if clinically significant, if it causes distress or impairment, then that behavior, called masochism, is returned masochistic disorder. For our purposes today, we'll just go with the shortened version of the word, as long as we're all on the same page, that the true definition includes the word disorder, just so we just save some syllables. Masochism, we already got, okay? Is there evidence of masochism in the Rector Picture Shop? Maybe not for Dr. Frankenfooter, but at least it's on demonstration, it's on display. Whether or not Rocky Horror himself gets sexual gratification from that scene that you already described, his wedding night. is a question we'd have to ask that character. So the film is a case depiction of masochistic disorder, of masochism. But we have to verify that with the character Rocky Horror. V, very. Voyeurism. What's voyeurism?
Watching other people be sexual with one another.
Right. And again, the behavior must result in sexual gratification to define voyeurism, and then rule in for being clinically significant to become disorder. Right? Is there any evidence that Frankenfooter may have voyeuristic disorder?
Kind of, yes, because at the end of the movie, he has them all on stage in like lingerie.
Even before that.
He watched them.
Yeah, he watches them in bed, in their bedrooms. Right, doing touch it, touch me. Listen to the lyrics. Yes. Thank you. E. Educated. Exhibitionist disorder. Any evidence that he disrobes to the shock value of others? Sure does. Sure does. Now again, if we ask him, what's with the shock? If we hear the answer including or alluding to sexual gratification, then yes. And then if clinically significant, then yes. Exhibitionist disorder. Father, F. Frauderism, frauderistic disorder. Any evidence? Frankenfooter, rubbing himself, his genitals, on others who are unconsenting. Rules in. What's this? Seems to be the quintessential case study of paraphilias. Wonder why I assigned it. Serfs, S.
Sadism, sadistic disorder.
Good. Right? Inflicting pain upon others or humiliating others, resulting in sexual gratification. Yes, you already identified the scene. Now we're switching our view from Rocky Horror to Frankenfooter. Yes. Porn, P. We already said pedophilia. Yes. It's an illusion. But again, we're talking about a child that's about a day old. 4, F. Fetish. Any evidence here? Not really. It's the only one. It's the only one. And then finally, T. Thrills. T. Remember his chief complaint? Or actually, remember their chief complaint?
Oh, transvestite.
Yeah. Transvestic fetishism. That's his
Oh,
chief complaint.
fetishism.
Yeah.
Oh.
Yeah, it's a two-part word. It's a two-worder. Yeah.
I see.
Yeah. Transvestic fetish. Or and this is a mouthful. Transvestic fetishistic disorder. So that's the full. Hence why we just keep the mini syllables. Yes, it's his chief complaint. He rules in for everyone but fetish. Now, there's actually a layer to this that very few see coming, and that is this idea of autogynophilia, and that is whether or not a biological male, because it's a condition that is identified predominantly in males, becomes sexually attracted of himself, their self, as female, because he demonstrates this. Right? All the times he looks in the mirror. A better case study, a better demonstration is Buffalo Bill in The Silence of the Lambs, right? Idaphne. Frankenfooter doesn't necessarily draw from that or get to that level, but it's there. The evidence of Autogynophilia. In someone with established paraphilia increases the risk of gender dysphoria. So it's actually clinically relevant here. Interestingly, there's a protective factor. That is, someone with a paraphilia with fetish actually is protected from, that is less likely to rule in for gender dysphoria. And it just so happens that fetish is the single paraphilia not in this movie. Right? So this movie turns out to be a case study not only of the paraphilias, of the sexual deviancies, but also gender dysphoria as well. And the evidence-based literature, autogynophilia, yes, fetish, no, further, I think, supports the diagnosis of gender dysphoria. So it's a very interesting, I think, finding that of all the paraphilias, all the sexual deviancies, the one that's not in there happens to be the one protected of developing gender dysphoria in someone with an established paraphilia. Other observations of the Rocky Horror Picture Show. Any other characters? We're good? We can leave it there. So, the paraphilias have average to below average shot of appearing on your shelf exam. So it's kind of a coin flip that you're going to see at least one. You now actually know, certainly I think, the highlights and what to look for to get the single best answer. In addition, we talked about gender dysphoria, and in addition, you will review the sexual dysfunctions, fair game in a psych shelf. Sexual response cycle, David Boer review book, visual information, match the two, and it's a great way to review those. Okay. We'll stop it here. We'll continue with our ode to Meatloaf at 12:30 and discuss what Fight Club is really about. Okay. Thank you back then.